morning, everybody. Welcome to day two to NHS Providers Annual Conference here in the wonderful city of Liverpool. If people haven't seen the Mersey, that's it, and that's Birkenhead for people who are less familiar with their surroundings. My name's Paul Rice. I'm the Chief Digital Information Officer in Bradford Teaching Hospitals and in Airedale NHS Foundation Trust in West Yorkshire. I am also with Adele, the co-chair of the NHS Providers Digital Board Development Network, and we can pick up more questions, themes and topics around that as we go as necessary. I'm sure you're all immensely familiar with it and have benefited hopefully from joining a range of the seminars that are run on a fairly regular basis with both local champions of digital and a number of our high-profile national colleagues. And there's a lot of resources that I again would advise and encourage you to look at on the website subsequently, because I mean it's absolutely essential that unified boards have an appreciation and understanding of the contribution that digital does, can and will make to all aspects of the way in which we organise and deliver health and care. I'm not going to say those resources are there. I'm hoping you're all familiar with them. I'm hoping and absolutely confident that if you're not familiar with them, you will be so inspired by the quality and quantity of this session over the next 45 minutes that you will race off and track them down before lunchtime. So without further ado, what I'll do is I'll just run down the panel in terms of giving you an understanding of who you're going to hear from this morning, rather than introduce people individually, and then I will use their four names to introduce them in turn, and each of them will give us 4 or 5 minutes of reflections on the challenges and opportunities around digital from their perspective and their sort of working and perhaps even personal lives. So Sonia Patel, first colleague to my right, is the Systems CIO and the Director of Levelling Up in NHS England. Again, please track down Sonia's biography. We were fellow graduates of the first cohort of the Digital Academy scheme nationally, and Sonia's got lots of chops around actually delivering digital into frontline organisations before she moved into her national role. Alongside Sonia's James Freed, and James is the Chief Digital Information Officer for Health Education England. Again, a graduate of cohort 1 of Digital Academy. So if you're seeing anything sinister emerge in terms of who's people in this panel this morning, it's absolutely not true. We're all good friends and colleagues. Alongside James, we have the pleasure of having Adam Thomas, who's the Chief Information Officer from the Dudley Group NHS Foundation Trust. And as I heard briefly beforehand, Adam's professional background is in pharmacy. So again, that's another perspective that we, in our multidisciplinary world of who are CIOs or CDIOs, I'm sure Adam will have a particular perspective in relation to that. And then last but not least, Adele Jones, who is the Executive Director of Transformation and Partnerships, who has travelled all the way up from Torbay and South Devon Foundation Trust to have the pleasure of sharing her thoughts with us this morning. So without further ado, Sonia, could I just ask you for some opening thoughts and remarks?
Yeah, thank you, and thank you for that complimentary introduction. So as Paul has shared, I have been in the National Systems CIO role for about 2 years, and previous to that I've got about 18 years of experience on the front line of delivering digital strategies and services. And it's a real pleasure to be here today because I feel this is a point in time where actually the digital conversation is becoming mainstream. So to have this as a conversation at NHS Providers actually marks, I think, the future around how digital is embraced across the NHS. And in terms of reflections, I mean, I'm also the head of profession for digital across the NHS, and that's a great pleasure and privilege. And I think there's 3 ways in which I see sort of building the right capability and capacity for digital in the future. So what do I need to do in partnership with others as a professional lead first? Secondly, what do we do as employers to encourage the right capability in the environments that we're delivering service? And then lastly, as employees, is there a responsibility on employees about encouraging kind of a prosperous future in digital within the NHS? And I'm largely going to reflect on the digital profession because to my right is my earnest colleague that does the wider kind of workforce digital skills sort of kind of programs and support. So as a profession, I think I have a duty amongst others, to work with both professional bodies, academia and industry to ensure that we are creating the right pipelines for future digital skills. And if I just give you some contextual information, I think this is quite important. So we ran a survey this summer, and presently we've got about 3,000 vacancies in the system for digital and data skills. And that's unsurprising, because HEE conducted a piece of research last year in 2021 that suggested by 2030 we need 32,000 new digital and data roles if we are to embrace the not even ambitions, the sort of kind of minimum expectations of what we might need to do for the NHS using digital and data. Now, those are fairly stark figures, but actually that's in the backdrop that there is actually just a UK PLC shortage of digital and data skills. So we are contending with other industries in this space. And from my perspective, healthcare deserves making sure we get the right support and skills in this space. So professionally, we've got to kind of take that challenge around how do we build a brighter future. The second bit is as employees. There is a responsibility, I think, as employees to think about how do we build and nurture digital and data skills and not seen on the side. And I think there's been a real shift over the last 2 years in terms of mindsets, and that's kind of broadly kind of leadership and broader board mindsets around digital and data. I think we've got renewed confidence in what digital and data can do for the system, because we've had many tries at this previously, but I think now we've got it right, the timing's right, we've got the skill sets, we've got the aptitude, and also we've got the will and belief to learn through the process, and it very much is. I mean, the theme of NHS providers is around resilience, and I have to say, digital can provide resilience in a number of ways, but it's not a silver bullet. You know, it comes with sometimes unintended risks. It sometimes is a bit of kind of a learning process as well. So that we need to create the environment that supports digital skills and capability to grow, but also understands that there will be trial and errors in that process as well. So that's from an employee perspective. As employees, I think there is quite a bit that probably we need to do in partnership with local providers and organisations to make sure we are nurturing the talent and the scarce talent we have across the system at the moment. We also need to make sure that it's an attractive place to grow as well, not just to kind of be a part of the NHS system, but how do you grow over time in terms of sort of your professional capability into different routes, and to provide real clarity around career paths in the NHS. Unfortunately today, we are recruiting to technology roles that we wrote 20 years ago. And you and I will know technology has changed vastly in the last 20 years. I mean, we've all using iPhones, which we couldn't have conceived of 20 years ago. So we do need to fix some of the agenda for change job families that we have to make sure we're recruiting the right talent and growing the right talent, and also aspiring to bringing new technologies that might help us work further and smarter around some of the things that we do. So we must look at agenda for change. I also think there's a big piece about shining a light on the digital profession. In some cases, unsung heroes and unsung heroines. So this year we launched the Year of the Digital Profession to shine a spotlight, particularly to those talented individuals that give day in, day out to the service. And this is really about the service, not just digital, but how that contribution is making a difference on the front line. So on that note, we've got some work to do to make sure we're encouraging roles. And I think the personal reflection for me as head profession is, whilst we are in a competitive environment, I mean, the NHS might not offer lucrative careers, but certainly we should ensure that NHS provides rewarding careers. And I think I leave you with that thought and hand over to James.
Thank you, Sonia. James.
Thank you very much. Thank you for having me. So Sonia's done a really good job there, I think, of presenting what the problem looks like and some ways in which we could try and tackle it. But I wanted to start by asking a slightly less vocalised question. So why do we talk about digital? how important is it in comparison to anything else that we've got to do? And that becomes an increasingly important question to make sure that we've all got an answer to at a time of stress. And let's not forget, even though every single year since the NHS has been formed, there has been a news article saying the NHS is in crisis, we are in stress. There is a significant amount of stress in the system right now, which means there is even more need to prioritise on the things that are going to give us the biggest bang for our buck, the most impact. In Health Education England, we have a responsibility to support the education of the workforce. Historically, it's concentrated quite a lot on the clinical workforce because that's where a lot of the levers are for education. Increasingly, over the last 7 years, in fact, we've also taken a responsibility, largely funded, actually, by Sonia and her team, thank you very much for that, to support the digital workforce as well, so non-clinical digital workforce, and the education thereof. But we've got a little maxim in Health Education England around what you do for a workforce problem. And there are fundamentally 2 ways in which you solve a workforce problem: more or different. It's a very simple truism, really. We spend quite a lot of time on more, actually, in Health Education England. There's more supply, and Sonia talked about the gap between where we are now in terms of the digital data and technology workforce and where we expect to be by 2030. And that is true for doctors or dentists or radiologists or pharmacists or every other profession. More is an answer, doing the same things that we do today, but more of it, which requires more people, more investment and more money. At times of stress, the word different becomes more attractive because it sounds like cheaper. It's not always the case, but it is a possibility. And when we talk about digital, we often talk about things like efficiency or productivity. And if I could refer back to the reason why we are all here. We are all here because we think that we can make the health and social care system a better place, and we codify that through something called the quadruple aim. But, better population care, better outcomes for patients, and better experience for patients, better experience for our staff, seen relatively recently actually as a real drive, and of course more efficiency. And collectively, we also, although productivity as a word isn't in the quadruple aim, that's kind of implied. We want to do more with less, or more with less. So why digital? Sonia talked about the pace of change, and it's kind of difficult to see the pace of change from where we are now. You've got to take a step back, take a slightly bigger view. There's a guy called Gordon Moore who I talk a lot because he created a law. Gordon Moore was one of the founders of a company called Intel. They are the people who produce chips who go inside your laptops. He made a lot of money on an observation that if you try as a chip company to go too fast or too slow, you will fail. You've got to keep to a very rigorous and rigid observation that every 2 years, I'm going to call it the power of computer chips doubles. The number of components on a computer chip of about the same size, about the same amount of money doubles. And he made that observation in the late 60s, and it's proved true to this day. And chip companies that deviate too much, they go bust. What that means is, broadly speaking, I'm dumbing it down a little bit, but broadly speaking, the opportunity that we have from digital data and technology in all walks of our life, this is not limited to health and social care, doubles every 2 years. We can do twice as much today as we could do at the start of the pandemic, broadly speaking. That different box is becoming more and more made up of different stuff through digital technologies data than it is through non. So if you're looking for an 80-20 rule, under stress, we need to be concentrating more on different. And right now, different means digital. That's why we're interested in digital. And fundamentally, and what the rest of our conversation, I suspect, is going to be about is, well, so what's digital? It's buying a bit of kit, isn't it? Buying a solution, that will do it for us. That is not true. So fundamentally, digital is about people, not about kit. And fundamentally, the team and building the right team is the cornerstone of making sure that you are successful in your business strategies, which need to be underpinned by a greater understanding and acumen around how we use these new technologies as they come on board, recognizing in 2 years' time, you're going to have double the opportunity than you do today. Thank you.
I'm terrified, James. You've fundamentally terrified me. But so I was initially going to go down the line and hear all 4 contributions, but actually my concern is there was so much richness and content from both Sonia and James that by the time we get to Adele with Best Endeavours, either your minds will have blown, literally, or you'll have forgotten some of the earlier contributions. So I'm just going to pause for a second, and I have Mike on the mic. Louise is not called Mike, but she introduced herself as Mike earlier on. So can I just check with the floor? Questions, conversation points, anything anybody wants to pick up from those first 2 contributions? Sonia outlined the challenges and opportunities for the profession. James scared the living bejesus out of us by the fact that Moore's Law says exponentially we're going to have more opportunities at our disposal every 2 years. Questions? Colleague at the front. Catherine's at the front. Oh, sorry, lady first. Apologies.
Okay, thank you. I'm Helen Ashley, Director of Strategy at University Hospitals North Midlands. So just interested in the observation about value and deploying digital tools. I'm just interested, and we might come on to it but just in terms of the panel's thoughts in a cash-constrained environment, how we continue to demonstrate the value of digital when it doesn't save the workforce, it's as well as. So just interested in the panel's thoughts on that, because the temptation to have less staff save cash is a real one, isn't it, currently?
Okay. I'm happy any of the panel want to pick that. I have my own views, having currently navigating the business case through one of the boards that I sit on. But
okay.
Thoughts?
Yeah. So I'm Adele Jones. I'm Director of Transformation and Strategy. So it's something that that I'm very focused on. I think it's important that digital is an enabler to a different model of care. So what James described around, you need to do it differently, don't you? You can't do it differently unless you put in a different intervention. So you change the work, don't you? So for us, for example, there are different ways of caring for people in their homes, but by using clinicians who are still based in the hospital through a HoloLens technology, who are providing advice, eyes-on advice from the carer who's in the home through this technology. Much more efficient, I would say, than the person driving in their car from the hospital to the person's home. So I think it's about productivity. So I think it's an and, you're absolutely right. But I think we need to start to major on identifying and understanding the productivity benefits. I did some work recently with PwC colleagues around what's really then the cost-benefit ratio of investing in EPRs and the benefits that you can get. And whilst there's great evidence base around safety and quality, really limited evidence base around efficiency. So I think it's up to us to start to create that by getting our measures right in terms of deploying digital and then really measuring the productivity benefits.
Okay, thanks, Adele. Any other comments along the panel?
I think I'll probably save mine for later, and I don't think I can trump Adele's comments there anyway, because I'd have said the same thing, and they are real challenges for us. It's really important that we're clear with what the value proposition is of investments, and we need to be transparent with boards where we are targeting our investment, where it occurs as well. But I think the wider capabilities and the need to have the right digital workforce to deploy it is key, because you won't get the value out if you don't invest in the people to do it. And so your point's well made, really.
Okay. James,
Yeah, thank you. So there's a big difference between the promise of digital and our lived experience in many cases. And that is because, in many cases, we don't do it right, basically. So one of the things that COVID really taught us was that there are 3 things that COVID forced us to do that can contribute to doing things right. So the first is a shared purpose, a real clarity of vision about the outcomes we're trying to achieve. And digital is no different than anything else. You're not interested in outputs. You're not interested in putting an EPR in. You're interested in real-world outcomes. And that outcome might be in reducing clinical errors. Or it might be in saving money. It might be in both. Both of those 2 are value, by the way, but it might not be necessarily financial value. So COVID taught us that focusing on one thing really helps. The second thing was moving at the pace of trust rather than the pace of process. You know, being able to empower teams to actually make decisions on their own. We're one, aren't we, for hierarchy and pushing decisions up the chain to the next steering group that's in 3 months' time, rather than empowering teams to deliver. And COVID really forced teams to deliver as quickly as they possibly could, and it empowered them to do so. And the third one was absolute focus on what we call a minimum viable product, an MVP. So we're also quite a one for writing a business case and then delivering something in 2 years' time. COVID did not allow for that. You know, for instance, telemedicine technologies, which the Topple review estimated would have an 85% prevalence across the NHS by 2030, hit that within 10 days of the COVID pandemic starting. You know, we moved fast to deliver slightly shonky things that worked. That's what an MVP is. And that just isn't, there's a disconnect between how we usually solve problems and how digital forces us to do so, or digital requires us to do so. So what I'd say is, if you can get in a situation where your organisation is able to do just that little thing extremely quickly, you can prove the value or not before you've spent significant amounts of money.
So I'm not going to go the whole way down the line religiously every time. I just wanted to make a chair's prerogative comment on that, just picking up two things from colleagues. I mean, one is the integrity of the position we put in front of boards in relation to the business case. To my mind, we really have got to have abandoned the version of half-truths that say this is going to be fundamentally resource releasing, it's going to cut clinical stuff. If we're still doing that and still trying to persuade boards of the integrity of that, I'd be very, very troubled by the likelihood of the success of that, or why the board would feel it have any rationale for backing you. The other point, I was just building on Adam's point really, is again, I've seen, and it's been interesting to contrast two organisations, but I've seen an EPR deployment in one where the model was heroically to deliver the go live, and then the resource to optimise and do benefits realisation vanished. So Kelsapri's, when somebody comes back and does a review of those benefits, they haven't been realised. The organisation's in a much better place. You'd never drive us back to a paper-based model, but fundamentally, if you don't keep that momentum, the change capability, the expertise that runs alongside digital transformation rather than the deployment of an EPR, then my view is that you'll never, ever get back to anything resembling the goals and the objectives that you outlined and that drove the ambition in the first place. So, but I think we're getting better. I think we're getting more honest with ourselves about both those aspects. The interesting dilemma with that, which I won't directly turn to Sonia, is and then the contractor market to actually get those resources in is inflated, and we're really challenged. But at least we're defining the problem, I think, in a much more honest and comprehensive way. So, Catherine.
Thank you. One of the things that you, or possibly haven't alluded to, is we talked about the development in technology. We talked about that capability and that exponential or fairly exponential growth. But with that comes complexity. And complexity in the environments that we're working in, not just as individual organisations, but now as part of ICSs, and the complexity in the digital solutions that support that. What's the thoughts on addressing that issue in terms of what does that mean for your workforce? And are you big enough as a single organisation to support that?
Yeah, Sonia.
I'm happy to take that question. So you touched on integrated care systems. I think they open up a huge amount of new opportunities. So it'd be fair to say that we've had a number of different eras around our technology experience in the NHS. I mean, we had many years ago a plan for one national system, national infrastructure. That didn't go as we planned. We then had a bit of a gulf where we allowed to cultivate, or for organisations on their own imperative to continue their technology journeys. I think we're in this third phase where what we're doing is looking at nationally supported and locally led. And I think in that agenda, we have an opportunity to work with systems to simplify their technology stack. So things that we know that are well proven now, there's huge opportunities across provider partners to look at shared opportunities of doing it together. A, to get greater value out of that asset, but also the scarce resource that are being spread across multiple different organisations, is there a better way to use that scarce resource? So it's all about how do you get value, not just monetary, but out of the scarce skills resource. There is also a greater opportunity around thinking about, if I actually see value in two parts actually for technology. There's one side of the value piece, which is infrastructure. So we would never question why we put a new unit onto a hospital building. We wouldn't ask, are we going to raise additional value for money by doing that? We know we need it probably because of the demand or the footfall. In the same way, some of the digital capability we have should just be utility now. We just need it to make sure we are secure, we are resilient in terms of providing the backbone we need around digital. The second part is where we can release additional value, the different, as James alluded to. And that's the bit where actually it may be that one organisation starts a new innovation, but actually it doesn't require all the provider partners to do the same innovation in the same space. We should be working much more collegiately and collaboratively to look at scaling those opportunities. So both from a national perspective, what can we do more to get you systems to great value, but I really think integrated care systems really need to look hard at their scarce resource and how do they release more value out of what they've got, and how do they keep creating value by actually kind of sharing and supporting each other with increased innovation as well. I think it's time that we stop doing things sort of 200 times over and really think about the kind of the new 42 ICSs helping engineer the right value both out of industry, market and our skills base.
I'm going to come to Adam, but again, I'm just going to reflect on that from a personal perspective currently. So I work across two independent organisations. One of those organisations shares an instance of an EPR with a neighbouring trust. We're in the process of building a business case for all three of those organisations to share a single instance. I work as part of an acute collaborative more broadly in West Yorkshire. We're the first of the organisations locally to deploy a new laboratory information management system, but that's a product which will then be, every subsequent NHS trust in the patch will follow. And we're all sort of working on a maxim that says share, build, buy. So we need contractors, we need a limited amount of specialist expertise, but if we're going to retain and sustain people in structured careers in digital in the NHS, we need to actively share more. There's a neighbouring organisation that's gone live with the same EPR. We've attempted to support their insights and so on and so forth. So I do think that spirit of collaboration and more rational decision making is alive and well, and is something that we should positively be looking forward to reap the benefits of as we go forward. There are going to be hiccups, but I think in practical terms the spirit is definitely there. But Adam, sorry, you were going to pick it up.
Yeah, it's actually a variation on the same theme. So I lead for digital data and technology for our provider collaborative, which is four trusts that provide acute and community services together. We are, because you need the subsidiarity of understanding what your technology is at your particular organisations, and that brings with it certain challenges. We're doing work together where we're kind of templating and blueprinting and then rolling out. So at the moment, we're doing a piece on behalf of the system to improve how the workforce can connect networks, and a member of the clinical workforce can move between those trusts and get seamless access. And we're doing that by linking it all the way back through the N365 instance to your NHS mail password. So we're simplifying that frictionless access. But all four providers would normally have been doing that themselves, and now we're creating a template, we're rolling it out, we're finding the problems and pitfalls, we're refining the model and then handing it over while other teams are doing other bits and pieces. So there's a way of federating out the expertise. And another example is a local provider, unfortunately about a year ago, had a major infrastructure failure that knocked out services. It was on the same technology stack that we use, so I instructed part of my team to support them in recovery, and another part of me and my team, we did the independent root cause for them so that their hands could be on recovering services and not the need to provide their board assurance. We provided that independently. So there is scope to find, I'm going to come on to talk about it, but there is scope to find capacity in different ways in systems, and the provider collaboratives are a good way of working closely to do that.
I know we have another question in the room, but Adam's just teed himself up there. I'm going to come on to do that, which is the chair's not paid attention to the clock, and there's a real risk that all my notes are not going to be shared for the benefit of the room. So, Adam, take the mic.
Thank you. It clearly wasn't subtle. So I'm Adam Thomas. I'm, as Paul mentioned, I'm a pharmacist, clinical pharmacist by background. I moved into digital in 2015, mainly compelled for two reasons. One, I was fed up of being in a clinic and not having the information I needed to give good experience of care, which leads to quality, etc. But also because I'm motivated about addressing health inequalities. And as an oncology clinician, we have really difficult outcomes for cancer, where I work in the Black Country, which is the second most deprived ICS in England. So I have a real focus there. I'm also, I should also disclose that I'm also a cohort 3 Digital Academy graduate. So there's, you know.
We'll practice our funny handshake later.
So what I want to talk about, I'm really fortunate to be in front of you as leaders, and collectively you will have shared or direct responsibilities in your organisations for delivering the different and delivering things in new ways and delivering services to address inequalities and the direct performance pressures that you face day to day. And to do that, I'm going to continue the theme of alliteration that we've seen through this conference. So we've built resilience by design into our digital teams by focusing on 3 things, and very similar to what James said. So we've focused on the 3 C's, which is capacity, capability, and contentment in work. They're the 3 things that we focus on in building our digital teams and our digital networks. I'm not going to talk too much about the capacity. I've just alluded to it, about how we're working differently in the system to achieve that. You do need to understand your digital workforce, though. In the last 5 years, our trust has grown by about 19%. The entire workforce has grown by 19% over 5 years. The digital team has grown by 2.2% in 5 years, and in real terms, that's 7 people across digital and data. So the exponential increase in the amount of devices and technology and demands for data that are in your organisations is huge, and you're probably not meeting the capacity gap there, demand and capacity. But when you focus on capability, you need to look at all of the things that are involved in making sure that you embed change. We've done, it's called Skills for the Information Age, known as SOPHIA, but we've done a full assessment of the skills in my team, right across it. So firstly, we looked at the roles we have and what skills are in those roles, but secondly, and more importantly, we've looked at where we're not deploying the skills we have effectively. So overlaid against that is the skills that we have, but we don't have roles for, and therefore we're not maximising it. So we've really worked on that piece of capability to understand where our gaps are. And like any part of the workforce, you need to understand your gaps because you need to start addressing them. We focused on putting in our contracts that societal value piece, but we've also used it to gain free training. So as we're moving to public cloud and cloud technologies, we've upskilled our workforce. They were very threatened by this new change from on-premise to cloud, and they didn't have the skills to necessarily go down that journey. But what we've done is used those contracts to get gratis training into the team so that they're supported. And when I was approached by our Deputy Director of Finance at the beginning of the year for the standard CIP chat, they said, you're going to have to get rid of or freeze your vacancies. I refused. I said, no, we're going to fill our vacancies, and we have. So we're under 2% vacancy rate in IT and at 12% for the trust. So I wasn't willing, that's a short-sighted view of giving up your vacancies to achieve something. So we filled the capacity and that we had, not increased it, and we've built skills in there. And we've also had a real focus on something I'm really fond of. I don't know if you've read the book The Founder's Mentality by Chris Zook. He focuses on 3 things. It's the owner's mindset. So you want your teams to think of themselves as the business owners. It means everything to them to get the outcomes that you're after as an organisation, so living and breathing the values. The second thing is that he focuses on insurgency, which might sound threatening, but it's about being spiky. It's about being a positive disruptor. It's about doing things differently and really getting in amongst that change. That is the way that you can start to make a real difference with digital. So you build those teams that want to deliver your organisational goals, and you maximise things that way. And the sort of final part that I want to cover really is that you have, as a leader, you need to have the commitment to be prepared to plan and then to put those actions into place. So where we've been recruiting, so for every Band 8A and above interview, I sit on the panel. It's really important to me that we bring the right people in that are going to affect changes, that they're going to be committed to bringing forward transparent and credible value propositions to the organisation, and that we build that capability together, and I want to support doing that in the right way. So I think that they're kind of key elements. I've also forgotten the last bit is really to advocate again, as was said, the importance of building capability into your board. So the presence of a digital leader, the professionalisation of the roles, and also the activation of your non-executive directors that come from other sectors that have digital expertise to really make the argument spiky, that insurgency, that why aren't we doing things differently conversation that should be happening at a board level. And I think that is important too.
Fabulous. Thank you very much.
Tal?
Adele.
Well, I am the imposter, aren't I? Because I've not been on any of these level 1, 3, whatever programmes they've been on. I'm an ops person by background, so with a long history of workforce redesign and service redesign. So that's kind of my background in my role. So why do I care about digital? Well, I think it's fair to say the people of Devon and Cornwall and our staff, if you would go to any of the hospitals across Devon and Cornwall, they would say that the rurality of our environment, the scarcity of the skills, so the scarcity of our workforce, the inability for anyone to buy a house in Devon because they've all got second homes and they're all on lovely Airbnb, and you come and visit us every year, and we love it. But actually that makes delivering services for local people really difficult. So our teams are desperate for change, but out of the 4 organisations, acute trusts in Devon and Cornwall, only one of them has invested in an EPR. So that's really interesting. So our ability to change and transform services is really hampered, and we're feeling that now, and our staff really believe that. So that's great, because my topic here today is to think about, so how do we get a wider engagement around digital in our workforce? If from our perspective, we've developed a digital strategy that underpins our transformation strategy. So if we think about the opportunity for an EPR through the Frontline Digitalisation Programme, what that could do in terms of connecting different hospitals, as Paul has described, to really change clinical pathways, to think about then how can we standardise clinical tools that people have in their hand at home to get care closer to home. We've got a massive opportunity to do that through digital. So that's why it matters to me. So our digital strategy is made up of 4 components. So digital readiness. So are we ready to accept and adopt the technology? So Paul's absolutely right. I've got a Tesla. I drive it like a normal car because I'm terrified of it. I've had it for 2 years, and I pretty much, every time I try and put it on the self-drive thing, it does weird things, it beeps at me, I turn it off and I just drive it like a normal car. and I think in most cases, that's what happens when you put in new systems in the workplace. People use them like pen and paper, but they don't necessarily optimise the opportunity that they provide. So we've got a huge opportunity to think about how do we help our workforce to really embrace technology rather than being terrified of the technology. So we've got digital readiness, making sure that in our transformation we really put technology in the hands of the clinicians so that they decide whether their clinical pathways can be transformed through technology. Supporting our citizens to be able to use our services through technology, because for many of our citizens, for those who have a kind of come from a deprived background, or you know, for their age or from a disability perspective, are we really making sure that our services are accessible? And then lastly, making sure that actually we've got the right level of mobile working and digital tech. So what we've done is we've kind of invested in two different elements of the work. So we've kind of done the basics, and we've done the transformation work. But all of those have been underpinned by what we call a digital lab. Now, actually, James, you've helped us with that, haven't you? Because there's someone in my team who's brilliant called Nick Perez. I highly recommend conversations with him. He set up a digital lab in our organisation, and we've got a digital futures team. And they do everything from baseline assessment of digital skills in our workforce to bringing small teams into deep dive, they call them deep dive sessions, into this lab, which has got simulation, virtual reality tools. They teach people how, you know, what tech can do, and they get clinicians interested in using the tech. So we've invested in those teams that start to kind of open up digital as being accessible. But, you know, the basics are far more basic, aren't they? So we have a lot of people who don't have the basic level of skills, and we cannot recruit and attract people from outside of our communities into our, you know, lovely seaside coastal town. But, you know, the average house price is beyond anything that the NHS could fund. So how do we start to grow our own workforce? So we've done that through partnerships with local FE colleges. Getting those kids who are really great at gaming, yeah? We've all got those, haven't we? I've certainly got teenagers who were fabulous at gaming, had no interest in anything else, great at gaming. If you put those kids alongside clinicians, you've got a great partnership, because they will design the tools for the future. Our clinicians will help them to kind of put that into clinical practice. So there's some great work that we're doing with local colleges around that. And we've got drop-in digital literacy sessions for both our staff, but also we're doing that for our digital citizens. So with the support of Healthwatch, we did a skills assessment around the skills in our communities, and then started to look at, so what could we do to support communities then? So for those who don't have access to technology, we've started to reutilise old bits of kit, so laptops, iPads, and gift those to those who are most in need in our communities. And we've got digital buddies who work with people in our communities to start to help them to be able to access digital skills. Transformation terms, we've started to embed digital into our normal transformation conversations or improvement conversations. So as an improvement practitioner, my commitment is to improve the work while you do the work. And digital's part of that. So therefore, digital's just got to be a part of everybody's vocabulary as we go forward. So when we're designing our service redesign, so we're part of the new hospital programme. In the configuration of our new hospital programme, digital underpins everything that we do. So we'll have a very different configuration of services as a result of digital. And clinical teams are really interested in that. We've got clinicians who come into the digital lab, and they'll bring problems, like specific problems with a patient, for example, who may be unresponsive on a ward, and using some of that virtual augmented reality technology, we're able to bring the world of Dartmoor or the beach that they loved into the ward for them, and the change that you see in patient outcomes, the responsiveness, because you've just brought someone's world back to them on the ward is palpable. So there's huge amounts of excitement in some of our clinical teams around using technology. So we get people excited about it, and then they bring their ideas to the digital lab. So what they do is they come to the digital lab and go, can you help us with this? I had a conversation yesterday with one of our NEDs who's got a great idea about using virtual reality in our care homes. We linked him into the Digital Futures team, and hopefully they'll come up with a great product. So for me, it's about making sure that digital is accessible. It's not scary. We've got people who can help coach and make it available to all, and it works on all levels. There will still be people like me who won't necessarily optimise it all, but actually, you know, I think it's like a boiling frog, isn't it? I'm in the water, and I'm just gradually getting hotter, and I've got no idea I'm boiling. I'm just using the technology. So what I would say is that the Digital Boards programme has been really, and I'm not just plugging this because it's an NHS providers event, the Digital Boards programme, if you haven't taken part in it, it's been exceptional for us. So we were a trust that I would say had more than a decade of disinvestment in IT. We didn't have an Adam saying no. We had people who actually allowed investment in IT to be cut over annually. Through the Digital Boards programme, actually, we've now got a board who is absolutely committed to the investment in digital and sees that as a key component of our future. And so if you've not been on it, and if you're not engaged, I absolutely strongly recommend it because it's made a big difference to us. Thank you.
Thank you, Adele. Sonia's wanted to come straight back in, and then I'm conscious we've got a colleague in the audience who's been very patient.
Ooh,
No, crack on. It's all right, all good.
It's just, I can't help after hearing from Adam and Adele a few reflections that I want to share. So if you look at the macro view, this is a whole system movement. We all need to work together if we are going to seize the opportunity of digital, but also kind of learn, and it's very much learn on that journey. And I understand that the Secretary of State mentioned sort of electronic patient records, so it would be only right of me to talk about some of the aspirations we have from the centre, because actually that's quite important, the signals we're making to kind of support that digital change. So when we talk electronic patient records, it's unfortunate we're actually referring to a system, but it's a great vehicle to make sure we're uplifting just the basic technology and the skills base in every organisation. And we've got proven experience in the NHS that electronic patient records make a huge difference, both to operations, to the kind of clinical outcomes for patients. More recent evidence is also suggesting greater productivity as well. So organisations with an EPR that is well developed and well implemented run 13% more efficiently. Now, maybe not cash releasing, but just think about that in productivity terms. Sepsis, we're seeing patients dying for sepsis, a huge reduction on implementation of EPRs. And the kind of list is starting to gather now because we're getting better at delivering on this. That is also, from a national point of view, we are re-looking at, with the opportunity, if we get full coverage of EPRs across the country, what does that mean for the conversation between national systems and local? How can we support local systems to achieve things very differently? We've got huge data burdens. We keep asking you for sit reps every day, hour maybe. But actually, if we could have the infrastructure locally, reduce the kind of burden and make sure we can support you with more effective conversations that empower local decision making and support as well. And I have to touch on Adele's point about consumerism. So I'm not quite sure that word quite fits in NHS, but actually we are on a revolution here around consumerism. So I think an earlier question was around value. I think we are just scratching the surface of what I think is a tsunami about to come around what our citizens might want of healthcare. And it's absolutely, to James' point, they want different. They're calling for different now. And that different is not just about the care that they receive in an institution, it's also the care they receive beyond the institution. So how are they supporting their well-being and their kind of their own management of their care conditions as well. So we really need to think about ensuring that organisations are not just setting up for short-term, medium-term operational sustainability, but also the longer term around actually how we might see that shift with our patients taking more interest, more charge of their care, but also making sure we do that appropriately and not leaving anyone behind.
Thanks, Sonia. I'm going to come out to the floor. I just wanted to make one comment on that consumerist piece. I've had an ab reaction historically for documents, some of which I've drafted, that had words where the NHS's position vis-a-vis our experience of banking, our experience of travel and leisure, our experience of shopping, sort of assert the digital divide ostensibly. I have to confess, I was in the US last week, and just because the unified comms platform operated by my airline, the amount of information that I was getting in an extremely timely manner, usually about delays, I have to confess, or usually about gate changes, it did feel like a completely different joined up journey, literally and metaphorically. And I did reflect again on, you know, we have to rise to that challenge. If that gap between the consumer experience and the experience of the processes of care get wider and wider, that's not a good thing. That is something that we're going to have to pick up with. I absolutely agree with the principle of electronic patient records is one of I call it table stakes for anybody who plays poker. But beyond that, that whole unified comms challenge, you know, a CAD will tell you when the delivery's not hitting the doorstep within the moment. United Airlines tell you when you've got to bust your ass to get from gate 109 to gate 173. You know, that's sort of how it works out there now, and we're going to have to pick up that challenge. So, very patient colleague in the centre. Thank you.
That's all right. Thank you. I'm David Williams. I'm Director of Strategy and Partnership at Leicestershire Partnership and Northamptonshire Healthcare, both community mental health trusts. And I guess I was just interested in teasing out potentially a bit more around the culture within the organisation and potentially exploring things through. Because I think there's maybe two bits to think about. That maybe the easier one is how does the NHS develop a better talent pool? Sonia, I think you started talking about at the beginning about people who are going to lead digital, because I do think we're a tough system to come into if you're doing digital from the private sector and other things, and I think that has a big impact on talent, and you were touching this. There's something about a culture that really wants to bring people in. But the other bit I think which is really interesting for us as organisations to deliver on is how do we get everybody in the organisation to do the basics well? And you just started to, I would have asked you something slightly different, which was we keep looking at EPRs as being the solution. And I keep going, once you put an EPR in, it's only the beginning, because if people don't stick any info into the EPR, there's nothing coming back out again. And I think that real drive to get the basics right in an organisation is really important in order to help us go forward on digital.
Yeah, I'm going to go right down the line on this one because I'm sure everybody has a comment. But I'm again going to cheat with Chair's prerogative. I'm nervous. I made a phone call this morning where I interviewed yesterday for a deputy in one of the two institutions that I work in. That's an employee from outside the NHS. She was head and shoulders above the quality of the other candidates. There were journeymen, and you can infer the gender of the individual. There were journeyman candidates looking for senior positions who were nowhere near what I needed for the future. I'm going to have to go, my chief executive happens to be over on holiday this week. I'm going to have to look her in the eye on Monday, and she's going to be confident and back me in making an appointment where we know there's a steep learning curve for that individual, but I'm confident she's the right hire. My other comment is just briefly that you may hear it down the line, brilliant basics. You know, it's a phrase fundamentally we've gone round and round and round in the organisation. Or I have another one which is probably not for the tape, but you can work out the acronym afterwards, which is SISO, and the I is in and the O is out, so you can work that out for yourself. If you're not getting that data at the point of care, you're spending an awful lot of time recovering your position in every manner and fashion. But I'll leave the expletives there, and I'll go down a much cleaner and well-behaved panel. So don't anybody want to pick that, Sonia?
So your 2 points, culture and basics, they're not mutually exclusive. I think they go hand in hand. And I strongly believe some of this has to come from the top. So board leaders and senior leaders leading by example. And I really do think, I mean, Adele touched, I think it's incredibly important that boards invest in their own digital and data development. Because only then will there be a greater appreciation and also building confidence around the opportunities plus the risks and plus the kind of learning curve that not just the board needs to go on, but you need to take the whole organisation on, and that is super important. I think then also, if you work with the boards and boards taking time out to walk the floor to understand what's working and not working about technology, too often you'll find it's usually the basics. And so therefore making sure that you've got that continual feedback at the board level and making sure those basics are being, I know that's not an easy conversation as well, having been there myself. You know, you're contending with infrastructure, estates issues, kind of clinical devices, but there's got to be something. I also think the big turning point around getting the basics right is moving moving away from the trend naturally in digital is pay everything out of capital. That's just not going to be sustainable. I think the big turning point is actually when you put some of those basics on your bottom revenue line as an operating cost of doing business. Once you've done that, I think you get to a place where you can reasonably optimize. And I, just on your electronic patient record, absolutely concur. It is not the solution for the world's problems or the NHS's problems. It's a vehicle. It's a vehicle and it's a catalyst in some extent to be able to take you on that digital journey that's much needed. But we've seen absolutely, and I know your trust well, you're seeing the opportunities of your EPR and what it can offer you. So in the same way, there's at least standard capability that EPRs can offer every organisation, and then it's really up to the making of the organisation itself about how far it might want to take it thereafter.
James?
Thank you. First thing I'd say is fund teams, not technology. So, and by the way, that doesn't mean I'm wading into the buy versus build argument, that we will always need both. What I'm trying to say is if your business case, and the concept of the business case, some of these things actually is also a problem. But if you start from the basis of a business case is that bit of technology is going to solve our problems for us and nothing else, then you will end up in the situation as has been described by the whole panel, where you invest a lot of money in a very nice Tesla that you don't use. The second thing I'd say is digital is a means to an end, not the end in itself. So collectively, we're there to deliver better services for our patients. And if you spend too much time thinking just about the means to the end, you end up being the builder saying, I've got a really great hammer, not I've got a track record of building amazing kitchens. So spend all of your time describing your kitchen and what it needs to do, and also think about the fact that you might need to go on some cooking lessons. I might be taking this analogy too.
That's all right. You were all right in the Tesla. It's blown up since then, James, to be honest.
Yeah, okay. There was an experience that I had that Adele may well have shared, that I know Sonia and Paul shared on this course that we all did, where as Chief Information Officers and Chief Clinical Information Officers, we were asked to look at the business case for the North Care record. A big business case, £50 million worth of business case, and we were given an hour collectively to try and present our case to the board. And I was thinking about, it was a real epiphany moment in that process for me. I watched as my colleagues tried to think what the board were going to say that might put the kibosh on this business case and then come up with an answer to it. I watched us tease apart, well, what if they say this? We've got to come back with this, or can we promise this, or do we think we're going to solve it this way? What we ended up doing is presenting why the board didn't need to be involved and reduced their involvement to just give me the money, I've got this, which we know doesn't work. We need to recognise that digital is not the responsibility, certainly not the sole responsibility of the CIO or the CDIO. It's a collective responsibility of the board. Every single person on that board needs to be a digital person. Whether they've got a qualification or not is immaterial. They need to recognise that there are a whole bunch of tools that help us deliver our services better. My view is, and I will second Adele on this one, I think the digital board's offer is absolutely excellent. There's a leadership guide on the NHS provider's website that's all about building and enabling digital teams. I was reading it again on the train journey up to Liverpool this morning. It's really good. The final thing that I'd say is digital literacy. It is important. Everyone is using digital more and more. We have invested in a digital skills self-assessment tool to help organisations help their staff recognise the need for their role, the need where they are at the moment, and plug the gap. There are 270 bite-sized pieces of learning in the back of that, and individuals will be shown the things that will help them get there. That will help them use the tools that are in place. It will also help know when to use things that are not in place that they can use safely and effectively. Thank you.
Thank you. I'm going to take chair's prerogative for just 1 minute and I'll invite Adam and then Adele to give you 30 seconds each. Last comments.
Yeah, culture. I won't disagree with the leadership from the top, and I think there's a question for everyone in the room to go away about what you're doing about leading the culture of digital in your organisations. I think there's a wider point about the grassroots of what you were getting at, is that the culture has to be led by clinical and operational and administrative networks. We're trying to build one, and we're trying to share that across our provider collaborative. But who's done it better in our area is the local mental health trust, Black Country Mental Health. I was having a conversation with their digital lead yesterday in the conference, and what they're really good at doing is building that network of people who are the digital expertise of a service and getting them to talk to each other. So in our organisation, the digital midwife talking with a digital pharmacist saying, hey, we found these problems, but this is how we got around it. And that starts to infuse the culture from the, I don't really like frontline, I'm afraid, because it kind of conjures up different themes, but basically the people who are delivering services need to own how they're going to work, improve and iterate, and you need to give them a framework of an improvement practice to do so that they can experiment. And we're afraid of experimentation in the NHS, but you should allow people to experiment safely, to progress things, to meet need, and that's the important thing for me.
Adele?
So the culture and the optimization bit for me is really important, because I agree with you. We need to believe that this is critical for us. And one thing that Paul said just reminded me of something that I've experienced recently. So my other half has had cancer and a successful operation. But one of the things that we noticed is that the NHS is a mystery. It's a mystery. Someone sends a referral in, you've got no idea what's going to happen, you've got no idea when it's going to happen. People will tell you that you'll have a test or an operation and you get short notice. You know, it would be like, so Paul's plane journey, you booking a flight to an unknown country, not quite knowing when the date will be, but we'll give you 2 days notice to change all of your plans. And these are scary times for the human beings in our services. It's scary. So as demanding as we are when we think about our banking, or we think about our shopping, or we think about booking a flight, it's more important when we think about our health, because when we need it to work, and we need to understand every bit of it. So I think back to the optimization piece, it's incumbent on us as leaders to make sure that when we put this technology in the hands of our people, they can make it work. Because if they can make it work and they optimize its capacity, actually as individuals, as human beings, when we need those services, we will be able to have all of the information that we need to look after ourselves and to look after our own well-being. So I just think we need to just get a bit passionate about it. This matters. Technology matters in our healthcare systems, and I think we need to start to just really put all of our weight behind it.
Thank you very much. I'll apologise to the colleague who used the technology, or the other technology, and asked a question that's appeared on the iPad in front of me. The panel will be here for a few minutes afterwards if they want to pick up that question directly. But can I thank you for your engagement and for your informative questions, and can I invite you to thank the panel in the normal manner for their contributions this morning.